we will continue to real science and real techniques. And who has ever done urodynamics has never seen artifacts. You all have seen artifacts, I think. And have you ever seen artifacts in published manuscripts? I've been counting in published manuscripts, and I've presented that at the AOA. I've been counting 170 pictures of urodynamics tests. And I think there were some 10 or 15 without artifacts. There were measurements published with one of the catheter measuring nothing, presented as one or another diagnosis. It's real. This is existing. So it's good to have you here, Andrew, and to show the artifacts. It took him many years to find those artifacts in your clinic, I think. And he involved everybody in England and far around. But he managed to get his hands on some of the artifacts, and he will present them today. Thank you, Andrew.
Thank you, Peter. Yeah, so urodynamics is a science and an art then. We have the science of measurement, and because it's an art, we're going to have some pictures of the artifacts that we would normally see. This is the basic module. There will be two. And the authors, along with myself, Professor D'Ancona, Professor D'Ancona from Brazil, Professor Kuo from Taiwan, and under the expert supervision of Peter Rosier. Here are my disclosures for this presentation. We're looking at common artifacts in water-filled systems. There's going to be an advanced module for other artifacts, rarer artifacts, artifacts in air-filled systems, that kind of thing. But for now, we're just looking at common artifacts in water-filled systems. Here's the definition. An artifact, it's good to start from Oxford for a definition, something that is not naturally present, but occurs as a result of the procedure. So these are not patient pressures. They are not signals within the patient. They are a function of the system or the machine. And we need to recognize them, and we'll deal quickly with these 9 so that it is possible to deal with them as well. We'll look at the main features of each, and we'll discuss how to remedy in the test. So first of all here, what is going on this slide? You can see that down at the bottom we have 2 areas where there is noise on the PDET trace. And this noise will get in the way of your measurements. What is it that's causing this noise? Can you see above on the first one, there is that noise on PVES, but not on the abdominal pressure. On the second one, however, the noise is on the abdominal line, but not the vesical. So in both cases, it comes down and is reflected on the PDET. These are high-frequency, short-duration spikes, and it's normally due to movement of the patient or a knock of the tubes. There you go. On the first one, PVES was knocked. On the second one, P-abd was knocked. We know that these are not transmission failures because of that rise in the middle, where transmission was checked, maybe a Valsalva or a deep breath. It rose equally on both, so we're confident that we do have transmission of pressure. So it's not a poor cough, it is a knock of the tubes. Well, to deal with that, you simply move the tube away from the area that's causing the knock. Tape it up on something or move it away from the patient's leg, whatever caused it. And when you're analyzing, ignore those spikes. Don't let any maximum pressures off those spikes lead you astray. Here's another one with a knock. Again, we can be confident that the signal is being picked up well because the rise in pressures just before that are pretty equal. However, there is a very obvious spike on the PVES line, and here an even greater one. Something's knocking the line. So again, what you do is move the tube away from the knock, try and identify what the problem is, and stop it happening in future. Different artifact this time. The cough at the beginning of this trace shows you that transmission is great. So what's happening? We've got an equal rise on both lines, and then an equal fall on both lines, and then a steady rise on both lines. They're reflected on both abdominal and vesical traces. What's going on? Well, your patient is moving. They're changing position. This is a water-filled system, and as they stand up, so that pressure rises. At A, they're probably supine, or seated maybe. At B, they stand up again. And as they rise, so the water pressure is greater on the transducers, because they're standing above the transducer. They then sit down at C. And as they sit down, it looks as if they've gone below the level of the transducer. So you have a negative pressure recorded. So what you do when you see this in urodynamics, equal pressures changed on both lines, is that you diagnose it as a change in position. And where the red arrow is, you move your transducers up to the level of the symphysis pubis. And you can see that's a movement because it's slightly noisy as you move it up the line. And also, it's a slower rate than your patient standing or sitting. So you can look at that and say, yep, this is your transducers being moved back up to the appropriate position, level with the symphysis pubis. And you can see once you've done that, both before there's a good cough and after there's good live signal reproduced on both traces, you've got good pickup, good transmission of pressure. Here's another one of the same situation where you have a patient position change and they stand up. So again, the pressure rises on the transducer because there's a higher water column pushing down on the transducer, if you like. But in this case, the transducers are not adjusted. So you can see that your baseline pressures are much higher than you would normally expect. So before this void, here, it should have been adjusted down, but maybe there wasn't time. Now you'll also notice on this trace that there's a suspicion of poor transmission of pressure. This vesical cough is much less than this abdominal cough. So when you look at the absolute pressure values, you've got 78 and a lower pressure on the abdominal, 50-something, giving you 25 on your pdet. That's quite a high pressure for a resting detruser. So it shows you that you've not only got to adjust the level of your transducers when they move, you've got to check transmission, because it can change as the patient position changes. And you've ended up here without that check and with an artifactually high pressure. Here's one last one on the position change. You can see there's a bit of noise where the patient stands up, again rises pressure, but this time we're going to measure urodynamic pressures when they're stood up. So the transducer's height is adjusted, you move them up to the level of the symphysis pubis, and that pressure falls to a normal pressure for a standing patient. So you can see as you move, you often get these tube knocks as well, and that's to be expected in a water-filled system. Again, you ignore that and you check afterwards that your pressure is being transmitted properly. You can now be confident for the rest of your test. Here's another kind of artifact. What's going on here? Specifically in the middle where our vesical line drops off the edge of a cliff. It's voided, yes. The vesical catheter has fallen out. And because the end of your water column is presumably on the floor, it is now below the level of your transducers and you get a negative pressure. Now usually this would happen on a void where you've got detruser pressure pushing it out. In this case, you can see actually everything's level. It's simply fallen out either by pulling or by being loose. And afterwards, when you try and get a cough test, nothing, of course, occurs on your vesical line because it's out of the bladder. So you won't get any corresponding pressure rise on a cough. So what do you do if this occurs in a urodynamic test? If you have not answered the urodynamic question, you've got to recatheterize. Put your patient back supine, recatheterize, flush again, and start from where you left off. It may be that your question has already been answered, in which case that's fine. But in this case, it may be we've got 600, 500 milliliters in the bladder, looking at that top line, and the patient hasn't voided yet. There's no sign of them having tried to void. I suspect that recatheterization would be necessary in order to test on those coughs if there is a leak at all, or what they do on a void. There we go, the vesical catheter expelled at that point. Now here's another one where the vesical catheter is expelled, and this time it is on a void. The pressure rises on the vesical trace, and the flow starts down at the bottom here. And as the flow comes up, so the vesical catheter is voided. And you can see that there is a spike at that point where the catheter falls out, so some extra urine comes with it, a bit faster in this case. So when you're looking at this trace afterwards, you've got to compensate for that spike, ignore it. Follow the line of the flow and figure out where that maximum flow point would have been without the spike in the system. The remedy, as I've said, if the urodynamic question is not answered, you might need to recatheterize. Now in this case, I'd suggest that you might feel that the urodynamic question has been answered. You've got a good idea of what the detruser pressure is, you can make a good estimate of maximum flow, and if that puts your patient definitely obstructed or clearly unobstructed, you probably would not need to do that test again. You could be confident that you have got an idea of their detruser function or their urethral obstruction. However, in this case, you can see that where the red arrows are, the vesical catheter has come out way before the maximum flow point, and there's hardly any flow to speak of anyway. But in this case, you probably haven't answered the urodynamic question. You've no idea really what the detruser pressure is at the maximum flow point. So you might well have to recatheterize and do the test again. So in all these cases, consider if you need to repeat the test when you see this happen. Slightly different case here. In this one, it's a little noisy because right underneath all these strains, you can see that the abdominal line, in this case here, has now gone slightly up and then fallen down, gone negative again. So what's happened to that one? Well, it's the abdominal one that's come out this time. And you would normally expect this to happen on a strain if it happens at all. And you can see here that these wild fluctuations in vesical pressure are probably reflecting that abdominal strain. And it's that has pushed the rectal catheter out through the anal sphincter, giving a little rise, and then falling again on the floor to a negative pressure. So this shows you that the expelled rectal catheter can sometimes come out on a strain. The same remedy applies, that if the urodynamic question has not been answered, then you may need to put it back in and test again. Of course, with a rectal catheter, you're not quite so concerned about sterility. So providing that the catheter has fallen on your mat or somewhere relatively clean, you can reinsert and carry on with the test without a great deal of extra effort being required. Similarly here, you can see that the rectal catheter has been voided again. A slight increase in pressure there in the abdomen again forced it out. But in this case, I would also want to check, once it goes back in, what the transmission of pressure is like. Because see, at the beginning here, these coughs are unequal, and I would want to sort that one out once the rectal catheter is back in. So in this case, you may well want to replace and repeat your urodynamic testing at that point. Different artifact now. something you may see on your traces, what's happening on that huge pressure increase on the vesical pressure line? You're flushing, that's right, I can see some hands moving. We're flushing through with the water through the dome, increasing the pressure greatly to push an air bubble perhaps through into, out of the tube and into the patient. And after you've done that, then you check that the transmission has been restored. And there you've got a good cough spike on both lines, showing that there's no air left in the system. There is evidence to show that these flush increases are normally above 200 centimeters of water, and they last between 2 and 7 seconds. So you'd expect them to be fairly wide on your trace and identifiable as a result. And when you've seen that on your trace, just ignore the peak. Some machines will record the maximum pressure as the top of your flush, which of course is irrelevant clinically. So ignore that maximum pressure. Here's some more flushes. You can see 2 now on the vesical line. And afterwards, there are 2 spikes showing you that the transmission is poor. It's been flushed again because the transmission was poor, and still we have poor transmission. So this is not due to air in the system. What's happened? Well, the line is open to the syringe. The syringe has been flushed through, and the tap hasn't been turned off at the top of the dome. I actually did this one, and it took me a while to realize that the transducer was open to the syringe. It's damping the signal. The cough comes up the tube, if you like, and gets lost in the rubber of the syringe. It damps it just like an air bubble would. Once the tap has been closed to the syringe, cough please, you're fine. The 2 spikes are equal, and you can carry on with the test. So the remedy is to close the tap and remember to check, using a cough test or similar, that transmission is still good. Now, the red arrows here, any guesses what's going on? Note particularly the infused volume at the bottom as a clue. This is right at the beginning of your urodynamic test. You're beginning to fill the patient, and there's a poor response on the vesical line, and then a flat response, no live signal being seen there. But then suddenly it comes into play, and you start to get some pressures. Does anyone ever see this? A poor response on the empty bladder. Yeah, it might be just the whole of your vesical catheter is touching the wall of the bladder. It has no engagement with the lumen, so it doesn't pick up pressure. Once you've checked for air bubbles and this poor response at the beginning here, flush through a bit maybe, and you still don't get a response, just fill for 50 milliliters, and you'll very often find that pressure response has been restored. And I would have done a check at that point to see that pressure had been restored. You do get some lines here, some variation on the detrusor trace, but that, as you can see, is in fact a rectal contraction. It's an artifact. That doesn't count in our slides because it is a real patient pressure, rectal. It's not an artifact of the system, but of the patient. And you, in good urodynamic practice, learn to ignore those variations on PDET. But right at the beginning, it's a system issue. You sometimes do get poor response on an empty bladder. So bear that in mind if you're convinced it's not an air issue. Another artifact here, what's happening on our abdominal line? It's fading away, and there's no response here to these strains that are going on. Suggestions. Water-filled system, remember. Rectal line losing transmission somehow. Sorry? Yeah, either blocked or empty. I mean, it's the same issue perhaps, that it could be blocked by feces, just stopping that transmission. More likely the pickup would be poor due to the water falling out or being squeezed out of the little balloon at the top. So you get a reduction in the transmission because it doesn't contact with the bladder, the rectal wall, and therefore no response to the coughs or the strains. You may or may not get that fall in pressure, but the remedy is the same. Refill the balloon. If you've got a little slit in the side of your balloon, it won't matter that a bit more water goes into the rectum, and you fill it up again, as is done at the end here, and you can see that the pressure is restored at the end. We don't see the flush here, it's obviously been switched off at the time, but the cough response after flushing is good, so you know you're back to good pressure transmission. Now this one's probably much more familiar to many people. Hope you can see that that first cough there is not a good response. They are significantly different. One, the vesical line doesn't reach the top of the line here, whereas this one goes right above it. So we have a poor cough response at A, a flush at the red arrow, and it's restored at B. And you can tell that because on the detruser line, you've got your single-sided spike. They're unequal traces, so your detruser registers a single-sided spike at A, but once you've flushed, moved the air out of the system, then at B, you don't have that spike on the detruser line. It's resolved. In this situation, however, it's not resolved. It probably is off the screen here because there's a series of poor coughs. And where you've got a decent response on the vesical line, so it's less on the abdominal, and at the red arrow, you can see the detruser has significant spikes. The answer to that would be to flush through your abdominal line a little more, put a bit more water in, and ask for another cough. And that should resolve your issue. Last example of an artifact, the 9th in our series. We've got small perturbations here on the vesical line, and they're coming through on the detruser. So whatever's happening is not being picked up in the abdominal. Any suggestions? What's going on? There's a drift? Sorry? Yeah, well, a moving patient, you'd expect something to come through on the abdominal line too. Breathing, talking, laughing, screaming would all come through on both lines. In this case, it doesn't. There's a poor response to live signal here on the abdominal line. Now, this could be, of course, just a little bit of movement or pump artifact where the lines are touching each other, the pump line and the vesical line. It might even be a double lumen line where you get this on one. You could stop the pump and check that to see if it goes away. But in this case, it's more likely to be a poor response on the abdominal line, just needing a little bit more of a flush. Even though the cough is good there, you might want to check, if this is a laughing or a moving patient, a breathing patient, you hope, that you've got good response, better response on the abdominal line. If you've checked it's not a pump artifact, if you've checked that there's no noise or nothing touching the line, then I would flush through and check with a cough that you've got a live response and a cough response on both lines. So that's the end of our basic module. I hope you'll be waiting in suspense for the advanced module, but for the moment we'd be very grateful for any comments or additions or extra bits of detail that you think we should include in our basic module of artifacts. Thank you for your attention.
Thank you. So, Andreas asked a question. Any comments?
Sure. Yes, and in fact, repositioning of the rectal catheter probably should be in there anyway, because sometimes you get a raised pressure as it falls down to the sphincter. So yes, perhaps we should add that. Thank you.
Who has a patient leaflet for urodynamics? So to inform the patient of everything that's going to happen. And who has mentioned in that leaflet, please try to arrive with an empty bowel. Have you written that in your leaflet?
I think so.
So that's in the Dutch leaflet. I think this is a good way of having. I think the abdominal pressure is sometimes more difficult to obtain than the intervesical pressure or the vesical pressure.
Definitely.
Who does push the 0 button after the start of the measurement, at the beginning of the filling? So that's not the ICS standard, and you lose the pressures. You lose the reference being the atmospheric pressure. So who does not use water-filled systems? Who does air-charged? It's the American system, more or less, or not? Not in yours. So most of you do the water-filled system, or do you use microtips? So in the water-filled system, it's relevant to 0 to atmospheric pressure before starting doing the measurements, and then fill up the bladder. And I think it's good in the module that you say in the beginning the vesical pressure is not easy to measure. So you need some filling of the bladder before it starts to record properly in some patients. Most of the patients starts to record good, but I think in some of the patients you have to wait for 20, 30 or 40 or 50 mils for a good pressure recording. Okay, some comments from you? Others? Okay,